Good afternoon, everyone, and greetings from the Climate Change Media Hub at the Asian College of Journalism. This is supported by Interlink Academy, Germany. We've been quite a few sessions now, but from a health perspective, this is a year-round challenge that extends far beyond seasonal heat waves. So today's session is all about mapping the climate change and health landscape in India. And for that, we have Dr. Jaya Sridhar and Aishwarya Tripathi. But first, like, why climate and health? Because reporting on climate change through a health lens is actually vital because it transforms an abstract and environmental crisis into a locally rooted systemic story that directly impacts human bodies and livelihoods. This approach helps journalists move away from simplistic, fear-driven, victim-only narratives. And this manifests in various ways year-round. These links between climate and health. They are seen in food systems and nutrition, vector-borne diseases, water health. It is seen in, it puts in a significant pressure on healthcare and infrastructure, labor, biodiversity loss. All of the impacts are seen and pressures are seen through our body, through our societies in the form of. So to show us how to do this and how do we cover climate change and health in a way that resonates with your readers, to have a conversation with Dr. Jaya, as I mentioned. Dr. Jaya is a medical doctor and a health journalist based in India with over 25 years of experience in public health and communications. She has an extensive CV. I will just focus on the fact that she has been a mentor and a mentor to several journalists for over 2 decades. She was Internews' senior health media advisor till 2025, and she's currently visiting Professor Sanvi Center for Planetary Health in Kuala Lumpur and Professor of Health Journalism at the Asian College of Journalism. Besides this, she's been on development of global guidelines for various renowned institutions, the WHO, UNAID, UNDP, UNICEF, and so on. So glad to have you here with us, Dr. Jaya, today. Aishwarya Tripathi is from UP and she's an independent journalist. She covers stories at the intersection of climate from rural India. She's the Oxford Climate Journalism Network and is a Population First and other institutes. Tripathi was interestingly mentored by Dr. Sri. And pick it apart to see how to do a good health story at the intersection of climate change. So now over to you, Dr. Jaya, and Dr. Jaya will speak for about 25 to 30 minutes, taking us through the extensive landscape that is climate and health in India, and then we will go to Tripathi.
Thanks, Mahima, and it's such a privilege to be associated with the ACJ for so many years. I feel like a fossil. Plus, it's also a real lovely opportunity to get to meet so many budding journalists who are all interested in climate change under the aegis of the Asian School of Journalism Climate Hub. So it's great to be here, and I do hope we have more conversations. I'm just going to quickly sort of direct your attention to this slide. As you can see, let me take these pictures down. Yeah. As you can see, the links between climate change and health, they work through about 10 of these interlocking pathways. You can see them all spelt out in a single slide. Very nice. It's from the CDC. And I'm sure you're familiar with most of these, and mental health impacts run throughout all of these, every one of these, whether you're an asthmatic or you're going through extreme heat, or you're a survivor of a flood or a severe weather event, or you're someone who's come down with whose home has been burned down, or whether you've come down with chikungunya, or every one of them has a mental health impact, which runs across all of these 10 interlocking pathways, which is why it's ranked in the center. I'm just going to, I know we've all sort of hammered the daylights out of the heat wave reporting. So I'm going to restrict myself to just a couple of slides on, let's see, I'm trying to move to the, yeah. Okay. Yeah. I'm just going to touch on heat waves and pregnant women in Rajasthan, just to give you a bit of a gendered view on how differently you can report on heat waves, right? So imagine you're a pregnant woman in Rajasthan and it's about 47 degrees outside. Your nearest primary health center is about 6 kilometers away. There's no cooling at home. You probably live in a little shack with a tin roof. There's no cooling at the clinic. And the walk itself can put your pregnancy at risk, particularly the more advanced stage of pregnancy you are in. So you could basically plan your story around 3 questions that can unlock the climate link, right? So who's the one who's suffering, right? Who's harmed? It would be pregnant women in rural Rajasthan who don't have cooling and who are walking about 4 to 8 kilometers to PHCs in about 47-degree heat, right? And who decides the health of these women? Who has a huge say over the health of these women? It's health officials who design the antenatal care protocols, the district medical officers who approve them, the state governments that write heat action plans, all of these. And I doubt whether you'll find any village in India with a heat action plan. So it's just beginning to take off in the cities, isn't it? So who benefits when the system fails, when the public health system fails? It's usually private hospitals that can pick up high-risk referrals after the pregnant woman runs into complications at the PHC or the upgraded PHC. So they end up treating high-risk complications that, after this preventive care sort of breaks down. What's striking is what we know as well as what we don't know. See, like we do know that research makes, research tells us that pregnant women are more vulnerable to extreme heat, right? Their bodies thermoregulate heat differently. We also know that heat waves are becoming more frequent and intense. We know that early warnings can save lives, but still, no Indian state routinely tracks whether heat waves are linked to preterm deaths, stillbirths, or spikes in maternal deaths. Spikes in maternal deaths, here and there are studies, but we do know that poor thermoregulation under heat stress in pregnancy can cause, preterm deaths and preterm births and stillbirths. Then there's the other, sort of an invisible chain. Besides leading to preterm births, you can have low birth weight babies and a greater risk of infant illness. You might face, lower immune strength in children, making them more prone to infection. So this chain sort of goes on, right? Or a second chain, a story could be that in the heat, the ASHA worker can't travel. She feels ill herself. The pregnant woman misses her ANC visits. Her hypertension goes undetected. And hypertension. Sorry? Yeah. And then you might have a maternal death due to eclampsia, which is complications induced by hypertension in pregnancy. So, but on the maternal death certificate, you won't find any mention of a heat stress. So it'll never say a heat wave was going on at the time or linked to heat or anything like that. So this is where the journalism comes in, right? Not just reporting the temperature, not just reporting the heat wave, but asking why rural pregnant women remain outside the protection of many heat action plans, and whether Rajasthan's maternal health protocols contain even a single line explaining what people should do when extreme heat becomes a medical emergency. It's just to give you a slightly different sort of a spin on the heat story. I'll give you another one, which is, I've given the link to it because there's no time to cover it, but there's a good story by Jacob Koshi on how increased ozone and during heat waves together increase the risk of cardiac illness. As we know, India's burden of non-communicable diseases has overtaken its load of infectious diseases. As of now, we don't know what's going to happen with climate change, but heat waves and climate change are going to amplify our chronic disease burden. Just leaving you with that. Here's another take on stories you could do about heat waves and their impact on health. This is going to be an indirect impact on human health, particularly the health of children, because of the impact on livestock. So your meat protein as well as milk supply are going to be affected because of the way heat impacts cattle. I'll leave these sort of studies with the links. You're going to get the presentation so you can explore this in some depth, right? So I'm just going to do, instead of going through every one of those 10 interlocking pathways, what we thought we would do is just take a deep dive into vector-borne diseases and climate so that you can apply a similar methodology to every one of those other 9 pathways. Okay. So a disease vector is nothing but an insect, like a mosquito, for instance, or a tick or something that carries a disease-causing virus or a parasite. So as the climate is warming, the geographical range of these disease vectors is getting wider and wider. The altitude is also, they're able to go into higher altitudes, and they are entering new geographical regions where they never were before. See, for instance, if you look at data from the CDC, Europe, they are finding that there's chikungunya very well established in some European countries, up to 369 regions from just about 104 regions 10 years ago. So there's been in 2025 alone, they've seen about 27 chikungunya outbreaks. We don't associate chikungunya with Europe, but this is what climate change has brought to their doorstep. Similarly with West Nile virus. I know many of you are not familiar with West Nile virus, which is why I put the symptoms over here. I think a few cases were reported in India as well. So you have a fever, joint pain, and rash, and so on. Unlike chikungunya, where you just mainly see the rash and then you find severe joint pain, it's known as breakbone fever, actually, in Africa. So this is just one data-based, evidence for you to show you that the geographical, sort of spread of the mosquitoes, of disease vectors, is extending. And then you're seeing that in regions where they already are common before, they're endemic to many regions, such as in Africa and India and so on, you find a densification. Their populations are going up, or those that had been brought under control are re-emerging after decades of subsidence. You find that the warming is lengthening their breeding season. And then the time between, you get bitten and infected, and then you start developing symptoms, which is the incubation period, that's becoming shorter. So, and of course, they also are equally irritated by the heat, so they tend to bite you more. So all of these things are adding up to increased vectorial competence. That in one word tells you that climate change is absolutely increasing the competence of these vectors to spread diseases. There's some data from the South Delhi Municipal Corporation. So you can check with the municipal corporations in your where you live to see whether they've been checking mosquito levels and so on, and they found that the mosquito density is nothing but in an hour, in a particular spot, one of the health officials will trap a number of mosquitoes. So how many can you trap in an hour? And they found that the mosquito density in South Delhi has gone up between 2021 to 2022. And you can see whether there's updated data on this. Just a word of caution here that when we talk about climate change, it's never usually a single factor linear progression. Ki weather is warming and then there's more chikungunya. We're going to look at attribution a little while later, but it's just that Delhi is also become urbanized at a ghastly rate, and the state of urban hygiene, breeding sites have increased, and all those are man-made, right? Spraying is not done properly, public awareness is low, so all of these things compound the vectorial competence of the that is already conferred on the mosquitoes by climate change. Here's another story. You find that coastal cities are at increased risk of mosquito-borne diseases because of climate change. So here's a good study from the ICMR, and they compared how much chikungunya or malaria or filariasis is there in a coastal place compared to inland regions, and then they tried to match those to changing climatic conditions. So this is the study period from about 2014 to 2023. They found in every one of these coastal states and union territories, most of the disease burden, the vector-borne disease burden, was much higher in the coastal areas compared to inland areas. And they matched that to rising temperatures and rising humidity, which were creating very favorable conditions for breeding and disease transmission. So as we know, coastal ecosystems are already, under threat because of increased salinity, which impairs women's health, BP and all of the skin rashes and menstrual issues and so on. And they also simultaneously becoming hotspots for mosquito proliferation. So it was a really interesting study. And here's another story one could explore, which has not been like fully sort of explored. Malaria expanding into higher altitudes. So imagine that, there is someone in Darjeeling or Kodaikanal where I am at the moment, or an Ooty. So you'll find that the people who are most likely to be worst affected are going to be the plantation workers or the other uh, tribes living in these places who've not been exposed to vector-borne diseases before. They don't have acquired immunity, they don't have bed nets, they don't have any awareness, they probably are not protected by any labor laws or anything, right? And who decides their fate? It's basically officials of the National Vector-Borne Disease Control Program, and then you have the state health secretaries at a higher level. And then just above them, if you look at the plantation workers, it's probably their contractor, the manager who manages them, as well as the plantation owners. And the people who sort of benefit from keeping vector-borne diseases in the hillside, in these hill towns, which are, hubs of tourism as well, they don't want to drive the tourists away, right? So they'll suppress it. Plantation owners won't talk about it. Tourism, hotels and others, promoters, they won't talk about it either. So where would you go about collecting data on this? You'll find that ICMR has data. You look at individual studies of insect specialists, namely entomologists, who are tracking the Anopheles altitude range, and you can look at the district National Vector-Borne Disease Control Program records. I mean, I've provided lots of slides at the end pointing you to various sources. But this is a good sort of way to look at, who's the one who's suffering, most impacted, who's deciding whether, to what extent they'll be affected, and who will profit from doing nothing, and who has the data. So what is the evidence that we have about this versus the evidence that's missing? If you see, there are some peer-reviewed modeling studies that have been published that says that Anopheles is expanding into higher altitudes, right? And WHO documents say that generally highland populations with no exposure have zero acquired immunity. So the first infections be very severe, right? But nobody has really tracked, if you go above Darjeeling, I think, which is at about 400 meters, if I'm not mistaken, if you go higher than that, is Anopheles present? Where is it present? Is it present the year around, or probably not in the coldest months of the year? But what is the transmission season? Has it increased? All of that data is not there. And we also don't have any idea about the occupational health provision for malaria or other mosquito-borne illnesses. So then you can ask for vector control spray map. So you can just, file an RTI and get the district malaria incidence. All of these things just to find out more information on the story. But here's something really interesting. No? If you look at district health officers, DHOs, pardon the acronym, which I'm very familiar with, but they use something called a digital vector control map. They are given that, but they don't help in the peak transmission season. So one of the reasons is because those maps are so outdated, even on the digital thing. And I'll tell you why. So imagine you're a DHO in Darjeeling trying to stop a dengue outbreak, which is currently going on, right? And you open your digital vector control map, expecting to see where the mosquitoes are breeding right now, which are the mosquito breeding hotspots. But the map is probably showing you where the outbreak was about 2 or 3 weeks ago, not where it's heading next or where it's happening now, because these maps are built with the wrong methodology. They're not predictive. They're built from existing case data, retroactive. So a neighborhood gets flagged up as a hotspot only after the people get sick and they get tested and confirmed, and then their addresses are entered into the system. So the maps are reactive, right? And they tell you where dengue has already happened, not where it's going to happen next, or malaria, right? The other thing is that climate-driven shifts are outpacing the data collection. As temperatures are going up and the dengue carrying mosquitoes or malaria carrying mosquitoes are moving into higher altitude areas of Darjeeling, that were previously considered low risk, the mapping system just fails to capture these shifts in real time. Even in Darjeeling, they can't do it. Where are they going to go and look for it in higher altitudes? And there's also reporting delays, right? Data from remote hill communities, and then that is different. You're probably likely to find lower cases of vector-borne diseases in the higher altitudes than the endemic foothills, right? Himalayan foothills. And they don't synchronize that. You need to know which travelers are carrying these diseases from the endemic area to the non-endemic area, and all of that is not tracked, right? They don't track where these guys are going. So the health workers just collect information in the field and they report it back. And so there's a structural map, lag before these maps are outdated. So the interventions, will really be, very late. So you'll find that mosquito control teams will end up coming to fog an area after the transmission has peaked. So what's the use? And testing kits and personnel will be sent to locations based on last season's patterns, not on today's emerging hotspots and so on. But in public health, timing is everything, isn't it? A map that's only a few weeks behind may not sound like a major problem, but during a fast-moving dengue season, and we know that can kill particularly the weaker, less immunocompromised people, those few weeks, that lag can mean the difference between preventing an outbreak and chasing one. So this is like a bit of a deep dive into the things you can look for in the field. And I'm sure when you listen to Aishwarya, you'll sort of relate some of what I shared here, right? So you can do stories at various levels. Let's say you're doing a state level story, right, on malaria. And then these national numbers or state-wise numbers, they only tell you part of the story. So climate change doesn't affect every place in the same way, right? A warming hill town or a flood-prone city or a drought-hit village, they'll all face very different kinds of disease risks. So mosquitoes breed locally, outbreaks happen locally, and you'll have to couple that with failures in drainage, water storage, and the state of quality of health services. So very effective revealing reporting, investigative reporting on vector-borne diseases, the more hyperlocal it is, the more illustrative it is, or it's much more of a likely to unearth something useful for public health personnel than just doing a superficial sort of a story. So try and connect climate change to what is happening on a specific village or in a specific place where people are falling sick. So here's just to give you a distinction between what you could look at the state level, right? You could look at shifts in transmission windows in, regionally, and investigate how warming temperatures have extended the malaria window by 2 to 3 months. You'll hear Aishwarya talking about this. So what is the state's healthcare procurement calendar? You can ask state level officials those kinds of questions. If you're looking at interstate migration of vectors, you'll have to track how, when the season is spiking in January, May, then it's a sort of a warning indicator for the neighboring state. And you can check whether the state-to-state data sharing exists. I have to share my favorite AIDS story here. In Tamil Nadu, we had a number of cases of HIV infection admitted with TB into our, Tambaram sanatorium. And at any given time, most of those cases used to be from Andhra Pradesh. At that time, Tamil Nadu was declared as a high prevalence state for HIV, and Andhra Pradesh was nowhere in the picture. But then if we were treating all these people here, naturally you wouldn't go to your local family doctor for an STD, right? Or say, doc, look, I have a problem down there, right? So if the health secretary of Tamil Nadu had just given the health secretary of Andhra Pradesh and given him a ring and told him that all your cases of HIV are coming to us, it looks like you have a major transmission on your hands going on in the state, please step up your surveillance, Andhra Pradesh might have averted many, many cases, right? So this interstate transmission of information, that's important. So there needs to be a system in place to do that. You can ask state level officials about this. These are all interesting stories you can do. And what are the cross-border trackers, right? You have high burden states like Odisha, Chhattisgarh, West Bengal, and so on. And you have about 85% of your malaria burden here. And then how are neighboring states dealing with it? Again, you're going to look at Uttar Pradesh, which is not a high prevalence state for malaria, but you're going to hear about it a little more. If you look at the district level, it gets slightly more interesting. You can look at tier 2 urban districts like Pune and rural Bengaluru or Lucknow. And then you can look at the real estate expansion there with rising Aedes mosquito counts, and then link up construction sites, lack of piped water infrastructure, all of these which lead to permanent breeding grounds for the mosquito. So you should be able to talk to urban planners and things. Then we already covered the high altitude. And then we're also seeing that equally drought drives vector-borne diseases, because of drought, the tendency is, whether it's a refugee camp or whether it's drought-prone districts, the tendency is to gather and store water, right? And when those containers are not covered, they become breeding grounds for vectors. So you can look at the Rajasthan districts. There's studies published on this. So you have the expansion of canal irrigation, and that's turned into a dengue hotspot because those canals are creating microclimates for Aedes mosquitoes, increasing the risk of dengue. So here you can look at more in-depth studies at the sub-district and the block and village level, where you get very, very interesting stories. You'll be able to meet the people who are infected, talk to the guys, the district health officials, and the village level health officials are on the ground, going from house to house. That's where the stories are. Okay, I'm just going to skip the scrub typhus, and which is a new thing, and this one is Kyasanur forest disease, which is linked to climate change, changing land use, as well as the transmission of these tick-borne diseases from primates and animals to farmers. So here I'm just going to give you just 1 minute on this one. How do you go about building a climate resilient health infrastructure? So right now, there's not going to be like a sweeping sort of a national plan for this. So what they're going to do with their very limited resources is that they're trying to position the resources and position the interventions at a far more strategic and logical, using a far more strategic approach. So what they're doing is just tracking the hazards, which are the blocks which are prone to extreme weather events. And then they will look at, in those places, where are the critical primary health centers placed and within these hazard zones, and then find out how to improve their climate resilience. I'm very happy to go into this at a future date, because these are really important climate stories that we need to do. We don't want our PHCs to get swept away in the flood and, not leave anything for the, affected people. So here you are, they do basically three things. They map the hazards, they sort of list out the exposure metrics, and they come up with a vulnerability score. And based on that, they will stock the backup water reserves, the medical supplies, emergency fuel, shore up the electricity supply, and so on. So that's how they are approaching it. So all this is relatively new, and I've provided a couple of links there that you can go and look up. This one you can read on your own because we're out of time, but I'm quickly going to go through a few slides on attribution science. So attribution science is nothing complicated in a sense on the face of it, but it is pretty complex. So scientists build two parallel worlds here. World A is a real world, right? The one with human-caused warming in it. And world B that you see on your right is a counterfactual. The same place, the same year, but with the climate we would have had without our emissions, right? Far bluer, greener, air far fresher. So they run both these simulations through the same chain. What was the climate signal? Who was exposed to it? What health outcome followed? Then they compare the gap between world A and world B. So without climate change, what would have been my risk for getting malaria or for getting a heat stroke? And then with climate change, how has my risk gradient increased? That's giving it to you very simply. So you can just keep this picture. And I'll give you an example. Okay. So this is how the attribution attribution works. You take climate change. Climate change in Delhi, we know that the unique combination of humidity and the air, the wind movement and so on creates a sort of an air shed above Delhi, which tends to trap pollutants, right? You club that together with air pollution, which is exacerbated during, seasonal crop residue burning. Although the coal plants are emitting about 16 times more of certain pollutants throughout the year, which we don't cover, the ones in Noida and so on, right? So your driver is basically the stubble burning, and your pollution signal is that PM 2.5 will spike, and your exposure pathway for people is that the urban population inhales toxic smoke. And then you might have emergency room admissions, asthma, or chronic obstructive pulmonary disorder, which is basically things like emphysema and bronchitis and so on. So actually the attribution finding is studies using satellite data and air quality models place about 40% of Delhi's worst winter pollution days, are attributed to crop burning. And you can attribute a fraction of that to respiratory hospital admissions each October to November. This is all you can say. So we can say attribution models link crop burning to a significant fraction of Delhi's winter woes or Delhi's winter wheeze or respiratory burden. That's all we can say. We can't say crop burning in Haryana is causing or driving Delhi's asthma epidemic, which is what we often see in the newspapers. The one message from this is look very carefully at the data and then only report the fraction and use the word attributable or link or associate, right? But don't imply causality where none exists. So what we're seeing is a clear correlation. Here's another one, which is less clear, right? You're seeing climate change causing, changes in monsoons, rainfall, and land use all combined together is causing the loss of vulture habitats, right? That's biodiversity loss. And then you're finding that vultures are dying also because the livestock they're eating, livestock carcasses, which have been impregnated with antibiotics like diclofenac, right? That's the adding factor to the vulture collapse. So your main driver is diclofenac use in livestock, which is, and those carcasses being eaten by vultures and then dying. And then a biodiversity loss coupled with a biodiversity loss of habitat and food and so on, which has led to a crash in their populations. And then that led to, if the carcasses are being left uncleared or uneaten by vultures because the vultures have all died off, you're seeing a surge in street dogs, feral dogs, which can cause rabies. And then the rabies cases are going up in human beings in that area. So your attribution finding is a 2008 study, I'm quoting from there, the vulture collapse cost India about 34 billion USD in healthcare and economic losses because of tens of thousands of additional rabies deaths attributed to the surge in feral dog populations, in rabid dog populations. So we can say diclofenac-linked vulture loss is attributable to a measurable rise in rabies deaths across India. It should be the that's all we can say. We can't say because the vulture population collapsed because of climate change, it caused rabies deaths across India. So we can't really say that. I hope it's clear. I know I'm like trotting along at a brisk pace.
Yes. No,
Yeah.
it's great. I was wondering if we want to go
Pause here.
to the trick question that you had and then maybe hand over to,
Yeah. So I just want to say that when you're talking about climate change as an upstream amplifier, it relates differently to each example. So find out where is your weak link and your strong link, and then use the language very clearly. Okay. This is another example, but I'll just go into this one. Okay. There's a very interesting study, which I've put here at the bottom. The link to the full study is there for those of you who are interested. And there's also it's a controversial study. You'll find some rebuttals and clarifications and so on. So we want to know, does warming correlate with farmer suicide rates in India? Okay. So what is the main driver? I mean, that is sort of well supported. There is a very, very strong correlation. The rising temperature, rainfall deficit, and then you're also finding that crop failure, farmers' debt, and so on, leading up to about roughly more than 67 suicides a year that would not have occurred otherwise, which are associated with the 25% rainfall deficits. Okay, that's very clear. That's a strong thing. But how and why does it happen? You can talk about the economic, financial desperation driving suicide. And you can also say that heat directly affects brain chemistry and mental health. So this is a well established but a separate heat suicide pathway, that in extreme heat we tend to be more stressed. It affects our brain chemistry, and those who already have suicidal tendencies, they may go ahead and take the final step. So it's likely that all of these pathways interact, but we can't establish a direct correlation or causality without isolating which pathway is the most dominant, right? So there's other compounding shocks. Like there was a pest infestation which destroyed chili crops in Telangana and Andhra Pradesh, driving suicides, at the time of the study. So maybe that added to it. So your climate statistic link is strong, but the causal mechanism is weak. So we can say rising temperatures are statistically linked to a measurable increase in farmer suicides in India, but we can't say that heat directly, drives farmers to suicide, or financial debt has driven them to. No matter how your interviews in the field might just give you that direct cause, tying it up to the climate angle using the study, but that is really the trick. So I think I'll stop there. Just look at this language. Instead of saying heat killed 300 people, just say that attribution models suggest heat was a contributing factor. Nuance your language. Scientists say climate is to blame. No, attribution studies indicate climate change increased the risk. So talk in risk gradients always. So the proportion of risk and what was attributed. Always talk to the person who did the study in order to ask him to explain it to you like he would explain it to a child. What exactly does your confidence interval, your p-value, what exactly are you attributing to exactly what? So get that very clear, record it, and then say it. So here are some sources for you, but I'll stop here. This is all stuff for you to sort of read on your own. I'll hand back to Mahima now.
Yes, thank you. Thank you, ma'am. Thank you so much for this overview, because it not only lays the extensive number of issues we need to cover, but also shows us how to do it. And also, you flagged the very important point of how loosely some of the news organizations and journalists tend to kind of just blame climate change, when a lot can be done on our end too, especially to prevent some of these outbreaks and so on and so forth. Now over to Aishwarya, but before I hand over, I just want to say that in your chat boxes, Pratish would have shared two links to Aishwarya's stories on malaria and how she used the One Health approach to kind of cover it. In these two India Spent stories, she examined how malaria persists in Sonbhadra district, Uttar Pradesh, despite India's progress towards malaria elimination. In the first story, she documents how terrain and scattered tribal settlements, migration across borders with four neighboring states. This is a unique district. It neighbors four states. And gaps in surveillance can allow outbreaks to go undetected. She used RTI. She spoke to several ASHA workers, villagers, and health officials, and so on. And in the second district, she goes on to kind of unpack the system that went on, that failed the people of Sonbhadra, and also solutions elsewhere that would have helped the people of Sonbhadra. So over to you, Aishwarya. We are at like 3:40. We might go 5 minutes over if that's okay, Preeti ma'am. And but like I'll hand over to Aishwarya now.
Great. Thank you, Mahima. Thank you so much for this opportunity. Like Mahima already said, I was mentored by Dr. Jaya for the story. So a lot of it is also her contribution. I'll just quickly share my screen. I'll just try to share my experience while reporting the story, the various steps and how the fieldwork, etc. went for this. So the first thing to look at was how the idea struck me. So I had attended a journalism training which was led by Dr. Jaya, and she was explaining the correlation of changing rainfall patterns and temperature changes with malaria. But some of the words which she were using made me curious. One of those were API, that is annual parasite incidence, which made me go through and the reports and look at the science, that what is API, what does this mean, how is this correlated to climate change. And she also shared the information that every district has an entomologist. I have recently, I think, learned how to pronounce the word correctly. Initially, I was so wrong at pronouncing it as well. It was that new to me. And then when I looked at the World Malaria Report, this was reported in 24, my story. So December 23, this World Malaria Report had come out, which had linked to malaria to climate change for the first time. And then the next step for me was I report from Uttar Pradesh. So how do I fit Uttar Pradesh in the picture? Let's say I was reporting from a hilly state, a colder region like, let's say, Uttarakhand or Himachal Pradesh. My story would have been about how these regions have not experienced malaria before, and now they're seeing cases of malaria rising in the region, and they're not prepared for it because they have not experienced it in the past. But Uttar Pradesh has had malaria before. So how do I bring that into picture? So that's when I linked that when I saw that in the reports, India government reports, it is shown that Uttar Pradesh is moderately impacted. Like it's not a high burden district, a high burden state for malaria. So then when nothing is, it's not a high burden place, and then sort of surveillance reduces. So my story idea was that how there can be re-emergence because nobody is looking at whether malaria is rising or not. Everybody is kind of at ease that yes, we have sort of, handled malaria, and this will not be a problem. To confirm that story, I spoke to 5 to 6 local NGOs who were there working in this particular district. Why I chose Sonbhadra, I'll explain in further slides. To confirm that, yes, it is a problem, something is actually happening. What are the local NGOs doing? NGOs who are working towards health, is malaria priority for them and stuff like that. So yeah, that's how the idea struck me. So why Sonbhadra? Because this was sort of like a local knowledge. I knew, I've heard as a child also, I've heard that Sonbhadra and Mirzapur, that belt is impacted by malaria. There have been a lot of cases in the past in this region. So I knew that there will be something happening there. But to report the story, it was not about whether it has happened, whether malaria has happened in these places before. It was more about if malaria has been an occurrence in these places much before, much prior to recent years, there would be specific malaria departments in these regions. Those might be more active, and they will have more answers and experience to draw from, which the story needed. Then the terrain was such that I also knew that when I'm talking about surveillance reducing, I have to focus on the terrain which can easily get neglected. This particular district has difficult to reach spots. It has hilly terrain, so much so that if you are taking a vehicle, you can't directly move from one house to another house. You have to walk at least 800 meters to 1 kilometer to reach the house to be able to report. So that was another reason why I chose Sonbhadra. Third was this was a unique district which was surrounded by 4 malaria endemic states. So I had an idea that if somewhere it is surrounded by it, it will be seeing some sort of malaria burden, because also Sonbhadra has thermal power plants and a lot of people migrate to Sonbhadra for work from these surrounding states. So those were the 3 reasons why I chose Sonbhadra to report from. Then how I developed the story, the checklist, health and climate story. I think first thing to check is whether science supports what you're imagining or what you're thinking to report on or not. So I checked the science, I read the malaria report, I read other government reports, I read some research papers, and it was making sense what we were going to report on. Then I looked at the publicly available government data, which is through National Vector-Borne Disease portal. And they have, it's not a very detailed in-depth data which is available on the website, but you get a sort of idea that, okay, fine, what are they trying to say, whether it has cases or doesn't have cases, which are the priority states, whether they're focusing on Uttar Pradesh or not. Then a go-to place is open, this Digital Sansad. For any story, let it be health story or a non-health story, I go to Digital Sansad, Lok Sabha, Rajya Sabha, check the questions, filter out if anything has been spoken about it in the Sansad. And then again, the previous slide, like it said, confirm with local NGOs. Another thing to do is I call up the Gram Panchayat leaders. Those numbers are already listed if you go and check on the websites of Panchayat. So for Uttar Pradesh, we have UP Panchayat website where all the villages, Gram Panchayat officials and the secretary associated with that particular Gram Panchayat, their number will be listed. So call the people up and discuss what is happening in their village related to that. So after all this, I had a rough storyline in my mind that, okay, fine, changing rainfall and temperature are changing the malaria trends. And now I'm supposed to find out how does it impact the community, what is happening with the community, and how are they tackling this. And also make a list of everybody who you would speak to for a health and climate story, because when you're on the ground and there's a lot of information present, it is very easy for these things to get missed out. So, if it's a climate story, you will be speaking to IMD, you will be speaking to, if it's a health story, you have to speak to ASHA worker, entomologists, the new word which I learned after Dr. Jaya's session. So I knew I have to speak to one. There will be district malaria officers. So all of this list has to be prepared beforehand. And what should be a starting point? Where will you go first? Will you go to the community straight away? Will you go to a PHC? Will you go to the district malaria officer first? So I chose not to go to the district malaria officer right away, because my idea was, if I go to this person who's in charge right away, he might become wary and he can, pull some strings and tell the officials or the PHC people not to give me information. So my starting point was PHC, where people were more open to discuss what is happening related to malaria there, how many cases do you get, etc. Then prepare a travel map. You might be traveling through different districts, different villages. So which village do you want to go to first? What makes better sense? Which one to visit first and which one is much further? Which day would you keep for which region in the district? All that can be sorted out before you hit the field. I have added some of these notes from that time from my diary to just give a sense of what I just spoke about. So I had clearly written down the crux of the story, that this is what I have to do, and some of the ground interviews which should be done, and what are the total number of blocks, which are the blocks I should be going to, some of the questions, preliminary questions which I have in mind, so that nothing gets missed out. Some reading has to be done, so that malaria, when generally I heard malaria, it was just malaria and mosquitoes. But then the more I read, I was like, okay, there's something called PF, PV, PF load is more in India. So when these officials or anybody speaks about PF and they don't say malaria in general, then you know what they're talking about. And other things that, what are the focus areas? What should I be doing once I'm on the field? Now, for the field work, there are multiple touch points when you're on the field. One very important thing is building trust. So, any health related story or sensitive information like this, when you go on the field, if you interact with community also, they're hesitant to disclose, and more so, I think, after COVID, because they feel that you might do something about it. If they are going and seeing a Jhola Chhap, you might go and complain. There might be some action against it. So they try to deny that their malaria exists or anybody in their family got malaria. And also because it is about transmission, they're hesitant that other people might know and they will be considered that, okay, they are transmitting malaria or something like that. So it took time to build trust, spoke to multiple people, sat with them for long without even talking about malaria, just discussing their regular day-to-day things. And that's how slowly they opened up and discussed things. Now, faring through contradictory information, some of the people might tell you that, yes, the government gave the bed nets, yes, we use them. Some might tell the government never gave anything and they don't give anything to us. And all of them are thieves. They go to the level where they're irritated with, the situations there. So you might get contradictory information. So how do you flush out that what do you want to believe and what not? So always good to speak to multiple people rather than talking to 13 people who might validate what you're actually thinking and finding. Speak to 30, 40 people, and then you will have a clear sense. You won't even have to decide whether this is true or not. The picture will emerge that what is the correct picture happening there. How do you talk to officials? Sometimes if you go with an accusatory tone to officials that this is not happening, why have you not done this? Chances are they'll shut you down and they will not try to share any more information. So I particularly, when I go for these things, I approach officials with a tone that this is what I'm trying to report on. I don't know stuff about it and I'm looking for information from you. And it goes from there. Some of them are more hesitant than others. For example, Uttar Pradesh state malaria head who I was handling, I went and visited him, I think 4 or 5 times, but he completely ignored and he was not willing to comment anything. And more so because I think he was also a little bit hesitant that there is something called climate change. He was in that denial. So he was hesitant to talk. So in that case, you look for, don't go straight away to the higher up officials, build it from down to top. Speak to official PHC workers, speak to lab technicians, speak to ASHA workers. They have their own malaria registers. That could help you. Next is handling too much disconnected information, where somebody's, because there's so much of information that it becomes difficult to connect the dots and make sense of what is relevant to your story. And that's when you have to remember this last point, which is highlighted, that is, remember what your story is. You have read your proposal, what you have written, the story idea, so that you don't get lost in all the information you're finding on the ground, and you have a clear direction when you're reporting on the field as well. Use your skills of local language if you know. I didn't know Sonbhadra's local language, which they were speaking there in the villages, but I know Awadhi, which is spoken in the villages in my region around this Awadh belt of this Unnao, Lucknow, Kanpur, etc. So I never spoke to them in Hindi. I spoke to them in Awadhi. So that happens. It makes them at ease. They open up to you and they're more comfortable speaking to you. And also, if they're saying something powerful in their local language, capture that local language, because at times in translation, that whole meaning and emotion gets lost.
Hi, Aisha. I'm just going to pause you here
Yeah.
in the interest of time. And maybe in about a minute, if you can just summarize the data parts that you kind of
Sure.
acquired through RTIs,
Sure.
and how you kind of built a more complete picture beyond what is available on digital
Right.
sensors or vector-borne diseases dashboards and stuff like that.
Mhm.
So if you want to kind of highlight that, and then we'll maybe take one question if possible.
Sure. So I'll move on from this fieldwork thing. This is again some of the notes I tried to share. And some of the practical tips which might help. Like, for example, this video is about how you meet people in their comfort space and not yours. So this woman who was standing amongst a group of lot of older men and other ladies, she was not speaking much and was just observing. So you have to observe also that somebody's body language, she's trying to indicate something. And she just said, you can come to my home and drink water there. And she took me to her home, and there she shared the entire story of how she has lost 5 of her kids to malaria in a span of a week. And that became the anchor point for the second part of the stories. And keep clicking pictures, don't keep your phone inside. It will become your memory map. For example, these pictures, right? They were not used anywhere in the story except this last one where this man is searching through the bag. But when you see this, you remember that how hot was it there? What all you saw, this first picture clearly gives you that indication. This set of pictures, only one was used. So, like, click more pictures. It gives you a sense of what is happening. Just one small point before I move to data, that be prepared with your backup plans when you're on the field. Because, for example, my train to Sonbhadra was supposed to reach at 7:30 and it was late and reached at 2:30 at night. And now this was a new place. I didn't know what to do. I put this picture to show, how dark it was there. And it was a bit scary. But then I called up the hotel guy, and obviously they won't arrange for car or something. And I requested if he can just ask somebody on two-wheeler to come pick me up. And he did. He did help me through that. So have some backup plans, practical skills, think on your feet, and it really helps on the field. Regarding the data collection, you should know beforehand what will be the source of your data. If you know that data is present, then you know that you will get it from vector-borne department or PHC or stuff like that. For example, recently now I'm working on a carbon market story, so I know that data is not present anywhere in public domain. I have to depend on private developers, so I'm very clear that whatever is publicly available, only that I can use. I can't file an RTI, so you should know beforehand. Before asking the state department, ask the PHC level officials, lab technicians, and district departments. Start from down to up. So my experience is, if it's a story related to health or anything which can, reveal some of the things which are not working out, if you go from top to down, chances are the top guy will instruct all the people who are below him in a hierarchy that don't share anything. And then once he says no, then nobody will share anything. So start from bottom. speak to people who are at the district level lab technician. They'll be more open. They'll be willing to share this. Observe what is happening around you. All these pictures are, in the local PHC center. Whatever was put on the Almiras or everything, I click pictures of everything. That also helped me find, okay, this also exists. And then the center, this register, this was shared by the lab technician related to this. The rightmost pictures of a Asha malaria register, which she had. Obviously the detailed data were not shared, like district level of the entire state data was not shared with me. So I had the Sonbhadra data, so I was like prepared that okay, I have the district data, but then I filed the RTI and got the data of all the district in the country to compare which state is progressing better, which state is not able to, and it had very detailed of annual parasite incidents, what are the PF rate, what is the PV rate, how many deaths, etc. So I think that's how the data collection went. I think I'm done, Mahima. Last bit that
That's awesome.
just handle your fears properly. A lot of things happen where, on the field, for example, this district malaria officer told me, if you have taken the data from our department, what is the point? I might just say that you came in and stole the data and there might be cops involved and stuff like that. So just be prepared. Nothing can happen. You have pictures, you have the printed copy where their name is written and their signature is there at the bottom. It will not happen. So just don't be scared. It'll turn out to be fine if you're a little smart about it.
Thank you, Aishwarya. It's also revealing that how we see health as a soft beat, but it's almost like a political issue too. There have been so many cases where health reporters have gotten into trouble just because they reported the truth. And especially hearing you and Jaya ma'am speak, one thing is there are a couple of interesting things. One is that there are so many departments and so many officials and so many experts within the government sitting there to do exactly this, prevent these diseases and track them. And as journalists, if we are supposed to hold them to account, then we really need to kind of start learning their names and designations and where they sit and who's not doing their work. And that's itself an interesting story. And the second thing is that there are just so many ways to look at the health and climate links. And with that, I will open it up to questions. There is one question in the chat for Aishwarya. Do you have any advice to cover climate for those without a science background? Maybe you take like half a minute to answer this so we can get one more question in. Yeah.
Dr. Jaya might have a more technical answer. I can speak only based on experience. So I don't have a journalism background. I've never studied journalism. I think if somebody doesn't have a science background, even those who have science background, we can't understand all of the science. Whoever's explaining you, the scientists, catch hold of them and, like Dr. Jaya said, tell them to explain it to you the way they would explain it to a child. And that's how I think you understand and break down things. Don't be hesitant to ask these basic questions. Be stupid. Let anybody think you're stupid and just keep asking the most basic questions till you understand it.
Yeah, I think that's a great answer. I always remember my colleague from the WHO who used to say, he used to say, Jaya, the only reason someone's a bit smarter than you is because they've read one paper more or they've spoken to one person more. So you don't have to have a science or a medicine background. Of course, it's an advantage. If you don't have it, with the help of AI, you can ask it to explain things to you. You can put a scientist quote into the AI and ask them to break it down for you in simple language. There are many websites that are offering plain language summaries like the Cochrane reviews and so on. So I think nowadays we don't have any excuses. More questions for Aishwarya.
Najia is asking how many visits you made to Sonbhadra and how long did it take to report?
I did three visits. The first visit was, I think, a week long. I think 8-9 days long. The second visit was again 5 days long, when the district malaria officer actually took me around to show some of the malaria camps, which were happening in the area. And the third visit was again to verify some of the things which I had found, because these places also, there was no network in some of the places. Like, people used to hang their mobile phones in mahua trees and sit on top of the tree because network used to be there. So it was not possible to call and confirm some of the things. So there was a third visit to confirm some of the things. I think it was a fellowship story. So the overall period was 3 to 4 months. Yeah, that was it.
Aishwarya told us earlier that this was 2 visits more than the person who was supposed to actually track the malaria in that region.
Yeah. I asked the entomologist, he was like, you went to Sonbhadra how many times? I said 4 times. Like, Arey, I went only twice to check. गाड़ी का खर्चा भी नहीं मिलता है, कुछ भी नहीं मिलता है, कैसे जाएंगे मैडम? हाँ, okay, fine.
And that's this also another story, right? Like the fact that budgets are so thin in the departments for almost everything, let alone malaria.
Right.
So just looking at what kind of allocation you have for some of these districts or states or villages where the incidence is so high, how do you even tell those stories?
Right.
Yeah,
I think it's a story in itself because this district malaria officer, he was very active and he said how much he fought to get a surveillance vehicle year round to do the malaria surveillance because the state was providing him the vehicle only for 2 monsoon months to do the surveillance. So and it's not possible to reach these villages without the vehicle. So I think it's a separate story, very interesting story to look at, I think, like you said, Mahima.
Thank you so much, Aishwarya and Jaya ma'am. I would urge everyone to go through their slides, especially ma'am's slides has a lot of resources, tips, guides, and examples on how to do these stories. There is one more question in the chat. Any disinfo about malaria you want to dispel? I think you can answer that in the chat, Aishwarya, if there is a response. I'll just summarize until then and we can wrap up. Yeah, so I was just saying, please do go through the slides and we will send them out to you. The next session, we will be emailing to whoever has registered and 1 second. Yeah. Thank you for attending today's session and 1 second, there's one more question. Okay, Aishwarya I'm handling some of the chat answers as I'm wrapping up. But just to say that there is a lot of stories out there on health and climate. Heat is the ongoing issue, which we always report on. It's extending its season and it arrives early, leaves late. There is monsoon, and then in monsoon you have stories of vector-borne diseases, but there are also other stories to look at how the health infrastructure is prepared or not, what kind of budgets they have for climate and climate resilience, what are the various departments, and also to go beyond just the health departments and look at the intersections with other departments. When you read Aishwarya's story or go to Jaya ma'am's slides, you will see that there are several other departments that can be involved, right from IMD to urban planners to various other sections of the government. So thank you for attending today's session. See you all at our next online session, which will be held on June 26th. Thank you for your patience and staying on for another 7 minutes, and see you next time.